Just
Yes.
shout. Ah, perfect. Okay, just to warn everyone who's not seen me speak, I'm a bit of an info dumper, and I've packed about 15 years of a special interest into about 35 slides. So we can't cover it all today, but you'll get the recording afterwards, and I'll give you enough time for screenshots. So don't feel like you have to absorb it all. But this is an area I've been involved in for a very long time. I had muscle activation myself. I've worked with it clinically a lot with complex CFS-ME patients, and I'm continually fascinated by the emerging research. So this is the agenda today. It's a lot. The TLDR is that histamine intolerance is about histamine. Mast cell activation syndrome is much more than histamine, and sometimes not about histamine at all, because there are so many other things that mast cells release that can wreak havoc in a person's system. But the main takeaway is that there's no one size fits all kind of protocol, because there's such huge variance in how people present and what works for them. So you kind of have to take what's helpful and dump the rest. And we'll return to this a little bit later. So firstly, diving into histamine. So what is it? It's most famous for being that allergy chemical, but histamine has critically important functions in the body. It's a signaling molecule in the immune system that helps us to coordinate the fight against extracellular infections. So large organisms like worms and fungi. It's a hormone in our digestive system that allows us to secrete stomach acid. But it's also involved in regulating our hunger and our appetite, and it influences our feeding behaviors and our taste perception. In females, it stimulates estrogen and ovulation, and it's also supports fertility and plays a role in uterine contractions. But more recently, we're recognizing its importance, or the importance of the histaminergic system in the brain, and its involvement in a diverse range of cognitive functions. So in the brain, it's an excitatory neurotransmitter. It's well known for regulating our sleep-wake cycle and promoting alertness and arousal. It's also a neuromodulator. So it regulates the activity of other neurotransmitters like the serotonin system and the dopamine system. And it's also involved in learning and memory and our reward systems, including our goal-seeking behaviors. So without histamine, we might struggle with focus and motivation. But so you can see, it's not just about allergies or even what happens in the periphery or the unwanted effects. Histamine can actually alter the way we think, the way we feel, the way we behave. Okay, so there are 4 known histamine receptors that are distributed throughout the body. So this diagram shows where these are located and some of the symptoms that might be present if they get chronically activated. So receptors we know work like a lock and a key, histamine being the key, that can unlock multiple doors, which allows this diverse range of effects. So the body's really clever in like repurposing the same chemical for lots of different uses. But when something goes wrong with this balance, it kind of backfires and we can experience a number of body-wide problems. So a lot of first-line antihistamine medications work by occupying these receptors. So histamine can't really get in to activate them. However, it doesn't really remove histamine from the system. So it isn't really sustainable in the long term because we do need histamine in balance. So histamine intolerance is where we are unable to clear histamine at the rate it's being released. So this name is quite misleading because there are a lot of factors that are intertwined with it, meaning that the condition can vary greatly between, from person to person. For some people, it could be absolutely incapacitating. For others, low-grade disturbance. So it's really a condition of histamine or disorder of histamine regulation rather than, just having too much of a good thing. It's estimated to affect approximately 1 to 3% of the population, which might not sound like a lot, but that's actually more than celiac disease. So this figure is also likely an underestimation. So it's more common, or it's getting increasingly common as we start to understand it better. And it's thought to be due to a deficiency in two key enzymes. So diamine oxidase is one of them, and histamine N-methyltransferase is the other. And we'll talk about this a bit more, but reduced activity of these two enzymes could be genetic, or it could happen as a result of illness. And it can also be drug-induced. So a lot of common medications, including antidepressants and paradoxically even antihistamines, are known to stimulate histamine release or to block diamine oxidase. So it's estimated that around 20% of the population currently take DAO inhibiting drugs. But this is actually a really old study. So consider, today's the modern day where the average patient is usually on more than one medication. This whole thing sort of accumulates. Okay, so because histamine is a neuromodulator and interacts with other neurotransmitter systems in the brain, this can directly or indirectly impact a number of psychiatric conditions and neurodevelopmental disabilities. And this list is continually growing. So for clinicians, you might be supporting clients with these diagnoses. We want to be looking outside of the brain and be curious about any co-occurring conditions that could give clues to this neuroimmune condition. So we see high rates of chronic gut issues or a significant gut episode like a gut virus or travel bug that someone picked up where after that their mental state was just different thereafter. It's very common to have allergies or history of allergy. And people might also have hormone imbalances, or the onset of their psychiatric condition might have coincided with a hormone transition like puberty or perimenopause. So we want to question, if their conditions, particularly if their conditions fairly unresponsive to standard treatments, because this indicates that something else might be going on and we need to dig a bit deeper. Okay, so let's talk about exogenous histamine. So this page, without reading any of the text, it kind of looks like a nutritionist dream, unless you have a problem with histamine. Because all of these foods are some of the highest histamine-containing foods. So in addition to the histamine that is produced by our own cells, a lot of food and beverages may contain it. Or they can trigger our cells to release histamine. And this then adds to this overall bucket load. In addition, several types of bacteria can produce histamine via fermentation. So fermented foods, which we're told we all should be eating for our gut health, that can often trigger histamine symptoms or headaches, kind of allergy symptoms in a lot of people, which is really frustrating. A lot of people get horrendous hangovers with wine, beer, cider, this particular group of fermented beverage. And also we want to be considering the gut. So we'll talk about that a lot in this webinar, but fermenting gut conditions like SIBO or dysbiosis, it can actually be like having your own brewery inside your gut generating histamine. Okay, so we're going to have to do some biochemistry, but we want to understand how we help people break down and clear histamine. So it's a monoamine. It's made from the amino acid histidine, which you'll get from the protein in your diet. And we have two dedicated pathways to clearing histamine. The first, as I mentioned, is diamine oxidase, DAO. So this enzyme breaks down histamine that exists outside of a cell, and we find most of it on the microvilli of our small intestine. So this point's really key because gut health is a key player in histamine balance. It's also encoded by this gene, the AOC1 gene, which is copper dependent. So we need to have enough copper on board to be powering this enzyme. And we also need good levels of manganese, vitamin B6, they're cofactors for this enzyme to work. Genetic variations with this gene can lead to reduced activity, so it's a genetic form of histamine intolerance. And we also talked about the medications that can block DAO, but look how common some of these drugs are, and often people are on a polypharmacy of these. Right, the second pathway is a histamine N-methyltransferase pathway. So this is expressed inside a cell and exists in most tissues. But this pathway is highly dependent on methyl donors or methylation, which is a bit buzzword at the moment. The methyl donors are molecules that give or donate a methyl group to other substances. So this process is called methylation. And key nutrients required for this pathway are things like methylfolate, B12, B6, betaine, choline, and the most powerful methyl donor is SAMe. So in the brain, histamine isn't reuptaken, unlike serotonin and dopamine. It actually has to be inactivated by HNMT. So this is important to know when you're working with people who have slower methylation because of their genomics. So people with the MTHFR SNP or the COMT SNP. This is an area where you can really make a difference. So we're all massive methylation fangirls and boys at Psychiatry Redefined. Okay, so this aldehyde dehydrogenase is actually involved in both pathways, and this enzyme's iron dependent. So think about your chronically anemic patient. Amongst the hundreds of other problems they probably have, like fatigue, it's going to affect histamine load too. And we also need molybdenum, vitamins B2, vitamin B3 for this enzyme to work properly. And it also degrades, as the name suggests, alcohol. So your lovely evening glass of red not only contains a bunch of histamine from the aging process, but it also blocks both histamine clearing pathways. So it's often why we might get headaches or migraines or histamine symptoms from wine. So actually taking some of these nutrients can really facilitate this and good hangover cure. Okay, so histamine and hormone cycle. This is such a big discussion and actually could be a whole hour into itself. But people might be telling you that their symptom flares coincide or map onto certain points in their hormone cycle. Or it could, histamine tolerance could have been triggered by a big hormone transition. So puberty and perimenopause are often really common triggers. And if their symptoms they're experiencing are predominantly neuropsychiatric symptoms like pain or anxiety or brain fog, they can often be dismissed. But mast cells, which we'll talk about a lot in a lot more detail later, they're one of the main releasers of histamine, and they express estrogen and progesterone receptors. Estrogen is known to trigger mast cell degranulation. So what that means is their membranes break down, they release their contents into the surrounding tissue. Progesterone tends to have a stabilizing effect on mast cells, and it also increases DAO levels or activity. So histamine balance is actually delicately intertwined with hormone balance. And just remember that our biology is not static, it's constantly fluctuating. Histamine symptoms often wax and wane and can be really, really hard for the person to make sense of. And menstrual cycles or times of hormone change can be a metabolic nightmare for one, especially transitions like menopause and adolescence, where you're also experiencing a lot of brain remodeling at the same time, and changes to the energy systems. It can be quite an unbearable time for some. Okay, so back to DAO. Estrogen lowers DAO levels, whereas progesterone tends to upregulate it. And we just talked about methylation, but for the practitioners out there, remember estrogen detoxification uses the methylation pathway. So this is going to compete for methyl donors at certain times in the cycle. So it makes complete sense why histamine symptoms might surge around ovulation, for example. So what we can do in clinic is increase our DAO and methylation support during difficult points in their cycle to make more of a difference. So when we're supporting histamine intolerance, it's not just about blocking histamine. We need a good whole body assessment to build a clinical picture that histamine might be involved in their symptoms. So we'll talk about lab work a little, but it can be helpful to highlight areas of need, but it isn't a substitute for thorough case taking. There currently are no reliable biomarkers, and they only offer a snapshot of a very fluctuating and dynamic system. So for many people, using a low histamine diet or protocol might be the only indicator of the condition. Okay, so baseline support, we usually lower the histamine bucket load and facilitate metabolism or excretion. And what really separates functional medicine or any holistic approach is that we try to get to the root and try to address the underlying causes to bring these histaminergic systems back into balance. So we want to know what's driving this. Is it the gut? Is it the environment? Is it hormones? And support really specifically here. So I'll let you all screenshot that. We won't spend time here as we've got a lot to go through, but this is a reference slide of what is available to practitioners as a first line and some of the interpretations in the context of histamine intolerance. And a lot of this is just standard GP, blood work that your GP or primary care doctor can access. DAO and histamine are available as a lab test, and I'll show you an example in a moment. But it comes with huge caveats because histamine is actually a really difficult thing to capture. It's metabolized in under a minute. So unless you're waiting there with a needle the moment someone has an attack, you might not actually capture the true extent. And DAO levels, as we saw, fluctuates around the cycle. So it's not really a normal level for the whole cycle. Okay, so in the absence of diagnostic biomarkers, clinicians will often use a low histamine diet to identify the condition. So the advantages of things like elimination diets are that you get to see exactly how histamine affects you personally. And you're generally looking for a remission for at least two symptoms from following the diet. Studies have found it effective for symptom relief when following the diet for up to 4 weeks. Beyond that, there was no further increase in the benefits. But in the real world and in our clinical practice, we find it can actually take 4 to 6 months for histamine levels to reduce. And they're also notoriously difficult to sustain. It needs a lot of coaching and nutrient monitoring because you're essentially cutting out a lot of healthy foods. So often people can get overwhelmed and just end up, kind of on a very restricted, repetitive diet, and it can quickly become a source of health anxiety and obsessiveness. So always refer to a nutritional therapist or dietitian. That could be a game changer. But we also to mention, if the underlying cause isn't addressed, symptoms can often rebound when a person comes off the diet. Okay, so the lists on the internet also greatly conflict because histamine levels in foods vary depending on like the freshness, the ripeness, the processing of it. And the individual response can vary day to day, depending on what's going on inside that person's body on any given day. So there's not really a dose response, or the dose response isn't really linear. A lot of people access the SIGI food list or Swiss interest group, which categorizes foods into like high, medium, low levels, something like that. But beyond just avoiding high histamine, there isn't much of a nutritional emphasis. So things like protein, fiber, plant food diversity, fats, things that we know are good for us aren't really addressed. So the person can actually end up worse off metabolically. So do refer to your RD or your nutritional therapist to help get support in this. Okay, so this handout, if you want to screenshot that, is a reference of some of the vitamins and minerals that practitioners will use in histamine protocols and some of the functions they facilitate. Most of these we've talked about already because they're part of the histamine degrading pathways. Okay, so this is just a summary slide for some of our clinicians out there who have all some of the lab tests that might be useful when we're wanting to know, why the person is struggling to clear histamine. So is this due to sluggish methylation? Is this gut related? So we might want to run stool analysis to establish if the source of histamine is gut fermentation or leaky gut or immune reactions driving inflammation. For some, it might be managing hormone imbalances or stabilizing these huge fluctuations that could help break that vicious symptom cycle. So Dutch tests can help individualize treatment plans. With these significant immune cases, you're kind of getting more into the realm of mast cell activation. So we'll explore this in a little while. But here, the standard histamine support, low histamine diet doesn't really do anything. So it tends to be a bit more of a complex condition to manage. So I just wanted to show you quickly an example of a test we might use. So this is like an intestinal barrier assessment that we can run. So it looks at zonulin's like a leaky gut marker. And it tends to be, not very dramatic. So this is kind of borderline high. You can see this person's got low DAO, kind of trending high histamine. So this ratio of histamine clearance doesn't look too good for them. But the reason we focus so much on the gut is obviously that DAO deficiency can be acquired through inflammatory bowel conditions, anything that's going to affect the integrity of the gut mucosa. This is quite well established in the literature. But this diagram here shows, what can happen when damage or dysfunction of the intestinal barrier occurs. So you have this protective mucosal layer, and then this single cell or a single layer of cells that make up your gut barrier. And their job is to keep the bad stuff out and transport the good stuff in. And if that becomes dysfunctional, it can set up a perfect storm for histamine intolerance. So remember, we said DAO is a brush border enzyme. So it sits on this microvilli. So if there's no microvilli, there's no place for DAO to hang out. So our histamine degrading capacity is directly related to this. Leaky gut is the condition where these functional proteins that hold together these cells become dysregulated in some way. And then they start to allow the entry of large proteins and peptides into the bloodstream, which can trigger an inflammatory response. We also have the malabsorption of vitamins and minerals, which sounds a bit odd because you'd think nutrients just float through the gaps. But actually, vitamins need to be specifically transported by dedicated protein carriers, a bit like buses, which chaperone nutrients to the places they need to be. So they don't float around freely knowing where to go. So we might not be able to absorb and transport copper or iron or folate for histamine breakdown. And then the final stages of digestion happen on this brush border by enzymes. So if you don't have this function, we can have partially digested carbohydrates and proteins, which we're not absorbing, entering the large intestine where your microbiome is. And it then feeds whatever opportunistic bacteria wants to take advantage of that situation. So this can lead to dysbiosis, which is this imbalance of the bacteria in our large intestine, or it can lead to a general lack of diversity in the microbiome. So for the gut health nerds out there, this is going to have a knock-on effect on our metabolic health and also our mental health. And it can also drive or perpetuate inflammatory bowel conditions. So this is a really quick summary of what we do, massively oversimplified, as I'm not taking into account things that we might find like infections or SIBO. But in general, we can reduce histamine levels in the gut by using binders. As the name suggests, they bind to things to prevent their absorption. And this could include medication and supplements. So you need to take these 2 hours away or 2 hours apart. But it will include things like carbonated bamboo, activated charcoal, zeolites, things like that statically cling to histamine and other molecules. DAO supplementation exists for those who can afford it, really expensive, but it can be helpful in situations where you just can't avoid histamine. They're made from pig's kidneys, so not suitable for our vegans, but pea sprouts are. And actually, they've been found to have a higher DAO content than a lot of the supplements out there, so you can utilize those. Probiotics can be really helpful, particularly where your client can't do fermented foods. Certain strains are found to be histamine degrading through various mechanisms, and I've listed these here. But the main thing you want to be doing is gut barrier healing. So here are all some of the suggestions of things that are really helpful, and this will make a difference in the long term. Okay, so take your screenshots. So finally, some nutraceuticals and polyphenol-rich foods and supplements that have been demonstrated to have antihistamine or mast cell regulating properties. So there's a lot of things here for you to explore, but my top three are probably things like nettle and quercetin and nigella sativa. So I've intentionally not included brands or specific formulations, but practitioners in the audience, go ahead and share your favorites with your colleagues. Okay, so there is a lot of overlap between histamine tolerance and mast cell activation, but they're also very different clinical entities. So looking at the complexity of it, this is often what people think mast cell activation is, compared to the reality of what's lying below the surface. And every one of these things are backed by research and intertwined with each other and can be really difficult to pick apart. So it's your person who has all of the things, and they're not ill because they're not trying hard enough, or they don't eat a healthy diet, or they're too stressed or too sensitive. They're ill because these are all horrible, vicious cycles that feed back into each other and amplify each other. So even with the best knowledge, these are really, really difficult to untangle. So let's look at mast cells. This is the absolute minimum I think we should know to be working to understand them. But they're the innate immune cells, and they're usually first responders and most abundant in tissues that interface with the outside world. So things like the gut, the skin, the lung. So their main role is immune surveillance. And they're sensors of stress. So this can be environmental stress, physiological stress, like heat or injury or infections, and it can also be psychological stress. And mast cells contain hundreds of preformed chemicals, including histamine, but also things like heparin, serotonin, proteolytic enzymes, tryptase, and these chemicals are stored in granules or sacs, and they're released when mast cells are activated and discharged onto the surface of a pathogen or into the surrounding tissue. This picture here is actual footage of a mast cell being activated and degranulating and releasing these preformed chemicals. But many of these molecules then trigger the production of inflammatory cytokines, which notify other immune cells to come and help. So it's a very controlled process. Mast cell activity is regulated by our circadian rhythm, just like everything else in the body. So there might be certain times of day that symptoms could flare up. Studies have found like patients with asthma or house dust allergies, they might notice flare-ups in the night or early hours of the morning, or people with urticaria hives are often worse in the evening. Mast cell activation syndrome is the instability, the overactivity or the hypersensitivity of mast cells. Or it could be that the environment around them are responding abnormally to actual normal mast cell activity. So it's not like an increased number of mast cells as with the condition mastocytosis, which is actually a bit more like a cancer of mast cells. They're multiplying out of control. You have a normal level of mast cells. They're just very unstable and hypervigilant. Okay, so this is could not fit this onto one slide, but these are the common symptoms reported by people with mast cell activation. So it's not unusual to have 20 or 30 symptoms in the same patient. The condition is multisystemic because mast cells are all over the body. So it tends to be functional or holistic practitioners that pick up on these patterns first. The one thing you can be sure of is that they are all connected. And what you'll tend to see is subsets or clusters of symptoms, which can give you clues to which systems to then prioritize in your support in that person. So as I mentioned, huge variation in how MCAS presents. There's no one profile. People respond to entirely different things. What worked for me could actually make one of my clients very sick. So the majority of these symptoms are chronic and low grade. That doesn't mean they're less debilitating. The majority of them wax and wane, which can actually make it really difficult to diagnose. So it can take decades, meaning people just get more and more ill. And there's usually a fair amount of medical trauma on board by the time people realise it's MCAS. So hoping that we're at a turning point now with more education. But I wanted to mention some overlapping conditions, especially those with neuroimmunological involvement. So people with these diagnoses here tend to be more vulnerable, or are especially vulnerable to MCAS, and possibly responsive to mast cell activation type treatments for their core symptoms. So have a look at this paper, but it's not, here are some of the kind of neurologic, psychiatric presentations, but it's also not unusual for symptom profiles to shift over time. Sometimes it can be because the main complaint, like pain or crippling depression or fatigue, are so overbearing that other symptoms don't really register until you resolve one layer. So a condition can definitely shapeshift. Okay, so let's talk about triggers. So what can cause a mast cell to degranulate? Basically everything. So mast cells will express receptors for hundreds of molecules. And they could be immunologic, meaning it's part of the immune system's conversation or chemicals, and things like cytokines or IgE that can result in an allergic response. But they also express receptors for a number of non-immune things. So we already talked about hormones like estrogen, but also molecules like opioids, which is often a really big drug reaction for MCAS patients. They often have adverse reactions to general anesthetics, for example. But also neuropeptides like endorphins or substance P. So this is a molecule that's associated with chronic pain conditions like fibromyalgia. So triggers can actually vary and be very individual to that person. But this is also the reason people tend to get more sensitized over time to more and more things, because as mast cells get more and more unstable, the trigger threshold's lowered, and it takes less of a thing to activate them. So it could start with like a big infection or, I don't know, a drug reaction. And then over time, you notice, right, heat's now triggering these symptoms, or foods or chemicals. Okay, so let's talk about mast cells and neuroinflammation. So they abundantly line the blood-brain barrier, and they have a role in altering its permeability. So like any barrier in the body, it's there to keep the bad stuff out and permit entry of nutrients and immune cells if needed. We don't really want it to be leaky. Mast cells are also located in close proximity to nerve endings and also within some of our endocrine glands, like the hypothalamus, the pineal gland, pituitary, and the adrenal gland. So mast cell activity is actually intertwined with our HPA axis, our stress response. And they also, we mentioned they modulate other neurotransmitters, so they can actually uptake dopamine and serotonin and secrete them. So this paper is a recent paper on the influence of mast cells in the autonomic nervous system. Highly recommend you check it out. But the autonomic nervous system is the automatic part that we take for granted, controls our vitals like our blood pressure, our oxygen levels, temperature regulation, blood sugar levels, and our cardiac rhythm, circadian rhythm. So when we have a condition like MCAS, we start to see disorders of the autonomic nervous system, and these can be very scary because usually we don't have to consciously think about, getting enough oxygen to our heads, or manually having to regulate our body temperature, or if our gut suddenly stops moving on its own. But this is what happens with dysautonomias. So this is a group of conditions that will include POTS. And one of the mechanisms behind this is through neuroinflammation, which is a very hot area of research at the moment, no pun intended. But mast cell mediators can activate microglia, which are the resident white blood cells that live in the brain, and they signal danger to the microglia. and they will respond by releasing more inflammatory chemicals. So in research, microglial activation is a proxy marker for neuroinflammation, and it's independently associated with a number of psychiatric and neuroimmune conditions. So most famously, depression, we work with that a lot in our practice, but also conditions like CFS-ME or the autistic spectrum, where it's thought to amplify things like brain fog, pain perception, and sensory sensitivities. Okay, so in addition, some mast cell mediators are excitatory to neurons, so this can amplify nerve signaling in the brain. So it's also been linked to things like seizure disorders, but also this amplification affects areas that process sensory information or emotions. So people can display a reduced tolerance to things like stress and sensory input. Okay, so speaking of stress, anyone with MCAS will tell you there's a direct correlation with their stress levels. However, it's not as simple as we'll do some stress management and it'll go away, because there are a lot of vicious cycles within this. We know mast cells are activated by neuropeptides, like corticotropin-releasing hormone. So this hormone is released by the brain. It tells our adrenal glands to produce or to increase cortisol output. So that's a stress hormone. But also then mast cells also make and release their own corticotropin-releasing hormone when activated. So it becomes this kind of positive, vicious feedback loop that can be really, really difficult to break. Additionally, mast cells retain a metabolic memory of previous triggers, which primes them to respond more severely and rapidly when re-exposed to that trigger. So you can see why it might be an advantage, like if you're dealing with an infection, to get a head start. But what this means for your MCAS patient is they need less of that stressor to trigger a bigger response. And that stressor could be physiological, it could be sensory emotional stress, it could be some innocuous food substance that's no actual danger to that person's life. But our neuroimmune system becomes hyper-vigilant. So this is sometimes why you might see practitioners recommend things like limbic retraining or the brain rewiring programs like DNRS or Gupta. It can be helpful to use neuroplasticity to try and turn down this alarm system. Okay, got to mention a lot of people with mast cell activation have connective tissue disorders because mast cells are abundant in connective tissue, and when activated, they release protein degrading enzymes, proteases, like tryptase or elastase 2. So elastase 2 is found to disrupt cadherin, loads of names of proteins, but these are proteins that form those tight junctions in the gut, for example, that hold together our intestinal cells and other structural barriers in the body. So that can advance things like leaky gut. They also dysregulate integrins. So this protein holds together our sheaths of connective tissue, so our tendons, our ligaments, our fascia, to give them structural integrity. So it can also flare, so this is why it can flare up conditions like Ehlers-Danlos syndrome or hypermobility spectrum disorders, where we have this lack of structural integrity and are just very floppy. So we can have more disability, more pain, random injuries without really doing anything. Okay, so final slide on inflammation, but this mast cells in the gut can generate new inflammatory chemicals or cytokines. This can inflame the afferent vagus nerve. So what I mean by that is we've all heard the vagus nerve, so it's part of our gut-brain axis. But actually 80% of that nerve sends information towards the brain, and only 20% sending information from the brain to the gut. So where you have inflammation in the gut, you're actually sending danger signals or signaling information to the brain, and this can actually generate neuroinflammation. But what we can also experience is visceral hypersensitivity. So this is the hypersensitivity of the gut itself, the gut tissue, and pain in that region too. and also gut motility disorders. So this is kind of the understanding of mast cells and IBS. If you think of your IBS patient, very sensitized gut, and it's a sort of nervous system, enteric nervous system issue. Mast cells also secrete mitochondrial DNA or mtDNA fragments and ATP. So mtDNA should be in a mitochondria in a cell, shouldn't be floating around the bloodstream. When it does, it augments the allergic response. So it really drives up inflammation. And these are proteins, so they need to be degraded. You can't just take anti-inflammatories, they won't go away. They actually need to be broken down by protein degrading enzymes. So practitioners often use things like serrapeptase, these bromelain, these enzymes to help break down these DNA fragments. Okay, so direct measures, so testing, direct measures are not very reliable outside of a controlled experiment, unfortunately, and they're not very practical, accessible, and can be a huge expense. So we do need more research, because currently there are no reliable biomarkers or even well-validated assessments. Tryptase is the most specific marker to mast cells. No other cells really secrete it, but it has to be measured within 4 hours of an episode, and compared to that person's baseline. So we don't really have that information to hand typically. And depending on the location or the trigger, mast cells can actually release other mediators without releasing tryptase. So it's a very controlled process. It doesn't just release everything. It will be very trigger specific. So it's not that reliable in all cases, and the current consensus is that you don't need this marker to diagnose MCAS. But in people with MCAS, as I mentioned before, low histamine diets and protocols are often not enough. So we need to consider, obviously, histamine support, but all of the other mediators and mechanisms that we've just gone through, largely centered around things like neuroinflammation, sensitization, hormone involvement, and possible complications like dysautonomia. The big elephant in the room is immune dysfunction, and obviously I can't go into this today, but this is where a lot of the underlying work has to happen, because mast cells are part of the immune system, which is highly sophisticated task force that evolved to outwit clever bacteria and pathogens. But when something else isn't pulling its weight, like our antiviral response, it's often first responders like mast cells that step in and overcompensate, but they can do this job very badly and create a lot of symptoms. So here's a summary or algorithm of sorts. So this helps organize your thoughts clinically, with these kind of steps that we might take to support someone. It can be really overwhelming to unpick it all. And what I'll do is, I don't know if we should stop for questions, but I'll run through a few of these. So if you want to review these later on when you're watching the recording, I've put some general support for mast cell for each step. So mast cell stabilization, for example. Bear in mind, every patient is highly individual, so you're not going to use everything on everyone. We have to really tailor it to the individual case. But we can be using things like bicarbonates to help stabilize mast cells after mast cell attack. Flavonoids are really popular. They stabilize the mast cell membrane. They bind to the estrogen receptor, hormone modulation, and they are unfortunately very badly absorbed through the diet, so we tend to have to supplement them. But luteolin, quercetin are two favorites. Slide's not working. It tends to need HPA axis or stress support. So adaptogens can be really helpful in attenuating this corticosteroid elevation under stress, and it reduces this detrimental effect that that stress can have on the immune system. So they can be really, really helpful to help break some of the vicious cycles. I put some kind of limbic system, vagal nerve things that we also do. And then when we consider inflammation, there's so many anti-inflammatories, we just want to be quite targeted. So things that are more useful, I guess, in the central nervous system, things like PEA can be really helpful depending on their presentation. Turmeric's, we kind of universally use that. Not everyone is able to take it. Can be really helpful. And some of your proteolytic enzymes for breaking down things like mtDNA. Okay, so, and this is a whole other part 2, but we have to consider immune dysfunction. So we're often looking at this triad of infection, inflammation, and immune dysfunction. So, most people have been exposed to something like Epstein-Barr virus, but not everyone gets sick from it. So we want to look at the individual rather than the infection. So when we're putting together protocols, we're thinking of the infection mechanisms, so antiviral hubs, but you'll find that a lot of them naturally overlap or are by nature are immune modulating and anti-inflammatory. So there's a lot of overlap here, but this is kind of a bit of a further specialism. Okay, so final slide, but when to involve a specialist. Obviously, when the person's not improving with interventions or getting increasingly worse and more disabled by the condition, the onset of dysautonomia can be really frightening. So getting support here and also, complex chronic infection cases can be difficult to manage on your own. Obviously, things like mycotoxin, biotoxin illness tend to go hand in hand with mast cell activation. So if this is not your area of specialism, you might want some additional support. Also hormone intervention, but we really need to be integrated rather than everyone doing their own thing separately, because the polypharmacy and everyone using a slightly different approach when it's not integrated typically makes the person worse. So you may need the person to continue to advocate for them because medical trauma is really, really common in this group. Okay, so just a few lessons I learned working with patients. Less is more. So our philosophy here at Psychiatry Redefined is start slow and low. So titrating to manage hypersensitive and complex reactions. A lot of people don't do so well on complexes because it's almost too complicated for their body to process. So single nutrients can be more helpful with supporting the body's natural regulatory processes rather than blocking or pushing certain enzymes. And remember, the journey is not always linear, so people can take 2 steps forward, 3 steps back. It can be quite a difficult journey. No two people are the same, as I mentioned, and trying to untangle, unpick multiple vicious cycles can feel like no progress is being made for long periods of time. But you will be making progress. The analogy I often use is where you have like a big ball of wool and things are tangled up and you try and unpick one part, but if that's not working, you might move to something else and try and untangle that. And it will be making a difference to the overall load over time. We know that pharmacology can be really helpful initially, but it can hinder the process later on, especially when someone's on a polypharmacy. Finally, when some of the superficial symptoms are resolved, we often keep going because there could be an underlying immune dysfunction. So we don't really want to flare up in a year's time or when the person next gets the virus. So sometimes lab testing can be helpful here to highlight, the immune dysfunction so you can work on these things behind the scenes. Okay, I'm going to put reference. Oh, where's the first page gone? I will send the references through. But yeah, that's managed to do it in under an hour.
That was great. But Claire, can you go back to your last slide? I think yeah.
This one.
No, to your slide. I just want to, yeah, right there, because we have a lot of questions, and looking through the questions, I will tell you emphatically, there are not answers to all your questions, hence the complications in this field. And as Claire describes in this list of when to involve a specialist, that list is just all part of our psychiatry defined training programs. Some are complex, some are challenging. I think what was powerful in this lecture to me is, as you put an umbrella over these symptoms, is just feeling so bad for so many of the patients that we've seen, that have been, I think you used the word medical trauma, being treated with multiple psychotropic medications for what is clearly a, inflammatory, immunological complex illness. So, in Psychiatry Refined, we discuss, many of these things from mycotoxins to hormones to dysautonomia, and we'll piece it apart, and we'll clearly be doing more dissection of histamine intolerance and mast cells. So I just want to thank you, Claire, for such a comprehensive overview and putting it in a perspective that I think is critical, and everyone will get, copy to listen more. But let's just go through some of the questions. I think tryptase came up a lot, and then you did mention it as a lab test that might or might not be effective. What is your kind of
On
sense
tryptase.
of where the tryptase test?
Yeah, so it's actually in the UK, it's really hard to get hold of, and it's kind of the proximity to the mast cell attack. So with tryptase, what is found is not everyone who has mast cell activation has elevated tryptase, because they may not be releasing tryptase. It is specific to mast cells, so if you do find a positive on that, that is a very clear sign. But it's just, to me, it's a window of needing to capture something within 4 hours of, it's just not that practical. So yeah, that's kind of my general thoughts. I think we tend to have to diagnose these things, which is why it takes so long, through exclusion, looking at the symptoms now with more knowledge. That page which was like with the obnoxiously small text, but the common symptoms, like seeing those patterns in someone could be a clear red flag.
Great. Are there any antibiotics that's used for MCAS patients?
Um,
Or let
antibiotics.
me, and the second part is, are there spore probiotics that
Yeah, so I
can
didn't
be?
I didn't include a pharmaceutical slide. I didn't feel like it was my place, but often I do show the different drug. I wonder if we can put it up on screen. There are different types, and not all of them are just histamine blockers. There are like mast cell stabilizing medications. So there's different levels of histamine or mast cell support that someone might be on. So a lot of the time when I work with doctors, they're on various drugs. There's things like LDN, which a lot of people are using. It's used in some of the trials, which can also work on the neuroinflammation, work on different mechanisms. Antibiotics, I'm not entirely sure. I think if the person has an infection, so when we work with like chronic Lyme or SIBO or something that is a chronic infection, um, by reducing the amount of, by reducing the infection, you have less activation, or less load on mast cells. But I'm not actually sure about that one. Yeah, not.
And have you seen COVID or mold exposure trigger MCAS?
Yeah, 100%. I think, I don't know if I put it in the slides, because I kind of focus a little bit more on psychiatry, but in my field, which is CFSME long COVID, 100% it does. Yeah. And that's kind of where I sort of went to the immune dysfunction piece, which is a whole other lecture. But that's where, so many people get COVID, but why do only certain people get MCAS from it? It's really to do with the dysfunction of their immune systems and which parts of the immune system are not functioning properly or pulling their weight. So if the antiviral response isn't very effective, and this is kind of stuff that we can test because we can measure T cells and we can measure immune, like white blood cell counts. we often see the overcompensation of something like an allergic response. So mast cells will be like, well, I'll just do the job. I'll just do it really badly, but I'll give it a go. And then you get this kind of chronic activation of symptoms. It's your body kind of trying to help, but doing it really badly. So yeah, in short, yes,
There are a
connecting.
couple questions, and I've heard this as well. Adverse reactions to the DAO supplements. Any mechanism or thoughts?
Yeah, I have had that. I'm not entirely sure at the moment what the exact mechanism is. Um, I d is it the form of supplement, or is it? I don't know if the person who asked that, or the people who asked that question.
It was just, yeah, taking the supplements to people, and I've seen it as well, and
Yeah, I've
I'm not
seen
sure
it
what the
too.
mechanism is.
Yeah, I'm not actually sure what the mechanism is, except for it might be gut related. But I don't, yeah, I'm not sure, but I've also seen it. I mean, we've seen pretty much everything I've put, like quercetin, luteolin, I've seen reactions to that. So it's so individual, and that's kind of what I meant. People have individual reactions. So yeah, I wouldn't want to guess what those specific ones are, but they're good to know.
Okay. Some of these are long. Did you mention bromelain? That can be
Yes.
helpful.
Yeah. Yeah, so anything proteolytic. So some people will use digestive enzymes on an empty stomach because you want to, um, anything that breaks down proteins, you want to absorb the supplement rather than have it stay in the gut and digest food. But a lot of anti-inflammatory kind of supplement formulations that we use, you might notice if they ask you to take it on an empty stomach, it could be um, because it could have protease enzymes in them.
Great. Okay, do we get time for two more questions? So what about niacin, low dose niacin for histamine?
Yeah,
Have you,
yeah, definitely low dose. So niacin can actually trigger histamine. So people who take it's part of that flushing reaction that people get when they do a high dose B3 because it opens up blood vessels. So low dose niacin is helpful for some of the histamine degradation pathways. I don't really dose B vitamins on their own because they work in synergy. And I think if you put a high dose of anything in, you kind of think of the consequences down the line metabolically, it can tip other things out of balance. So I tend to only really dose something like that in a complex.
okay, so last one, a couple melatonin questions related to dosing for MCAS, and then we'll have to call it.
Yeah.
Is it-
With that one, our slow and low, everyone has an individual dose. I don't do mega doses of things. So there's different from studies, it depends on the person. So sometimes I'll use it where it overlaps with